introducing Sanjay is, for me, quite special because he's somebody who has been sort of a fellow traveler that I never knew about until recently. When I was working, as Shirley was saying, as a frontline doctor in Mozambique, a few years after I left, Mozambique underwent what was called a structural adjustment program, which is a well-known series of austerity programs that were imposed on most countries of Africa and many of the poorest countries in the rest of the world on the basis of a sort of market fundamentalist point of view that by shrinking governments and reducing government expenditures, you could free the private sector to do wonderful things. And it was a disaster for Mozambique, where what had been a expanding health system that was providing a wonderful social safety net for people with lots of nurses, increasing numbers of nurses, with increasing numbers of health facilities, just stopped about in the mid-80s. And what Sanjay has been able to do is he's been able to describe that in many places of the world. I read a piece by him called Austerity Kills, which made me read his book, which is about austerity around the world and in this country, really giving us a sense of how these policies have very real impacts on people's lives. He's an amazing guy. He's a clinician, an internist, and assistant professor at Stanford, although I don't see how he can stay an assistant professor with 115 publications, but he manages to do this. But he is the director of what we call the Analytics and Modeling Core for the Stanford Precision Health for Ethnic and Racial Equity, which I thought was interesting. They call it SPHERE, the collaborative center now. He's a graduate of MIT, was a Rhodes Scholar at Oxford, where he got his MSc. He got his MD and his PhD at Yale University, so he's reasonably well trained. He was named one of the top 100 global thinkers list in the Foreign Policy magazine in 2013. So we've got here a pretty amazing guy. He does research on anything from TB, malaria, malnutrition and food, water, non-communicable diseases, which apparently is an area that he's moving in now, all in the context of government spending, privatization, and understanding alternative mechanisms for international aid. It gives me great pleasure and delight to introduce Sanjay Basu.
Thank you. Thank you for that introduction. It's a privilege to be here. I'd like to contextualize the premise for my talk today with the following conceptual framework. The framework that I'd like to start describing some research from the perspective of is if we believe the last several decades of work, particularly in social epidemiology as well as in a number of other fields within public health, that argues that much of health disparity or inequality originates from social and economic determinants, right? Perhaps codified recently in the WHO literature on social determinants of health. Then in theory, we as people within the public health field should be interested in the effectiveness in the real world of various programs that intend to alter social and economic circumstances. It stands to reason that we shouldn't just be satisfied describing some connection between social and economic factors, poverty, housing, employment, and so on, and their health outcomes, but we should also be really interested in how well poverty relief programs, housing programs, employment programs, how well or poorly, as it were, are actually mitigating health disparities or improving health outcomes. So that's my starting argument. If you can accept that premise, then what I'd like to talk a little bit about is the degree to which we know how well or how poorly different social safety net programs, programs that are trying to alter or intended to alter somehow social and economic determinants of health, how well they're actually doing. And nested in that question are two fundamental problems. One is a set of methods problems that I hope to describe and offer some, I think, hopefully new or helpful strategies in order to overcome, and a very fundamental political problem, which is how then does one translate from doing research to addressing the world in which we're, of course, talking about White House with the Donald, right? So in that context, a very real context, let me begin by talking a little bit about this central dilemma that I hope to describe the research on, which is how can we make social safety nets effective from the perspective of population health and population health equity? So in spite of all the rhetoric, let's begin talking a little bit about the data, which is what do we spend money on in the United States when it comes to this perspective of federal spending on social safety net programs? And I'll clarify here for a moment that I'm not going to, very intentionally, I'm not going to talk about some of the biggest portion of the spending here, which is on Medicare and Medicaid, or other health care insurance. I'd like to actually directly address this challenge of real underlying social and economic determinants, not just insurance, because insurance, which is hugely important, has been so heavily discussed. I think there's already a lot of literature. What I think is even harder to study are these early social and economic determinants of health for which the mechanisms affecting health might be quite circuitous or long-term or really complicated, and therefore making them very hard to research. And if we look at the various spending patterns in the United States, you see that they're not small, although they may be smaller than some other OECD countries. They're not small portions of federal outlays that are spent on various programs. One of the largest, in the lighter blue shade, is called SNAP, the Supplemental Nutrition Assistance Program, what used to be called the Federal Food Stamp Program. I'd like to use that very large program as a proportion of the budget as an example of a broader set of principles that I'd like to illustrate related to the challenges and potential strategies that might overcome those challenges for studying social safety nets, and in particular some of the dilemmas we might have in studying how a social safety net program might ultimately impact health. And what I hope to show you is that it has very little to do necessarily with the food stamp program or any other program, and has very little to do with whether it's a US context or another context, that the dilemmas I hope to address are fundamental really to studying any sort of social program and its role on population health or health equity. The other reason I chose SNAP is because no matter where you come from, which school you come from, what discipline you come from, it's probably fairly easy to agree that something affecting nutrition in the United States may, in theory, have some effect on health determinants in the United States. After all, a large portion of ill health in the United States is related, in theory at least, to nutrition, and so it's not a very hard, conceptually, a hard mechanism to go from a nutrition program whose title is Nutrition Assistance to health outcomes. If you can accept that premise, let me at least describe to you some of the dilemma with actually studying the program. To give you a bit of context, in terms of actual spending and the amount of people affected by my example program here, the Supplemental Nutrition Assistance Program, currently approximately 1 in 7 Americans are participants in what we used to call food stamps. I think that's a profound statement, right? 14% of the United States. Of course, correspondingly, spending is actually quite a bit of money, on the order of $80 billion, so not small amounts of change. But it's interesting to note how the program is actually operationalized from the perspective of an individual participant. No longer a stamp, the SNAP program is now a debit card that you use just like you would use any other debit card at a grocery store. Most people get approximately $4 per person per day worth of nutrition assistance in the program, although that varies based on a myriad, about 67 pages worth of 4-point font size details. Okay, truly fine print. And what one can spend it on is also a bit complicated. One can buy canned, fresh, frozen foods as long as they're not prepared. You can't get a sandwich from the deli counter because that's a prepared sandwich. You can't go to a restaurant or a fast food chain or so forth. But you can buy the components of a sandwich and assemble it at home. Now, SNAP has been much criticized. Certainly, the easiest criticism is the idea that it's not actually sufficient to supplement nutrition. There were some interesting studies which asked the question of, given how much SNAP dollars a typical person receives, could they achieve the basic minimum for what is currently recommended by the federal authorities to be the dietary guidelines for Americans? You can debate about the nature of the dietary guidelines, but could one actually achieve that minimum? And the answer is yes, you could achieve that, getting a typical amount of SNAP benefits. In fact, the SNAP calculation is designed for that, only if you purchased a very large amount of lentils and made a lentil soup for yourself, froze it, and then defrosted a small portion every day and ate that for all of your meals. So in theory, it's achievable. It would produce a remarkable amount of flatulence and probably not be very comfortable for anyone. So needless to say, people don't do that in reality, and it's not very reasonable. But here's a dilemma. So what's remarkable about SNAP, before you look at the data here for a moment, what's remarkable is, from a public health perspective, we talk so much about chronic diseases related to nutrition, right? It's the subject of nearly every magazine subscription near the grocery store counter. It's the subject of so many public discussions. It's the subject of so much public health literature, chronic diseases related to nutrition. So surely a program that affects nutrition in 1 in 7 adults in the United States, or people in the United States, 14% of the overall population, should be extensively studied by the public health community. And yet, in fact, the actual number of peer-reviewed papers understanding the effects of SNAP on public health are remarkably small. They can fit on one page when cited in full. The amount of papers, however, in the economics literature is tremendous and often focuses on questions such as degree of effective subsidy of the supplemental nutrition program for large agricultural producers. That's the title of one of the most cited ones. Matters like inelasticity or elasticity, meaning how much does changes in price of food affect the amount purchased. An extraordinary amount of interest. One of my colleagues, who is one of the country's profound, most pronounced and most cited experts on the SNAP program, is University of Iowa's ADM Korn Chair of Economics. So one can understand who is interested in the SNAP program and what most of the literature has been focused on. In the last few years, however, a small amount of public health literature has studied this program and its relationship to health. This table is an example of the type of finding that's been very common in the public health literature. In this case, the authors, who are at a renowned Harvard T.H. Chan School of Public Health, compared SNAP participants to non-participants in various metrics of chronic disease, waist circumference and various features of the metabolic syndrome, such as triglycerides, so-called bad cholesterol, HDL, so-called good cholesterol, blood pressure, fasting glucose by various metrics, and the overall metabolic syndrome associated with type 2 diabetes and future cardiovascular disease risk, and noted, in some cases, significantly worse outcomes among SNAP participants than SNAP non-participants. Now you might be saying, appropriately, that is entirely unsurprising. Aren't, by definition, SNAP participants poorer and worse food environments and so forth? And certainly that's the case, and the authors, of course, thought of that. And so they did what many of you poor MPH students have been subjected to in your R or SAS or SPSS class, which is to do the various multivariate regressions or propensity score analysis and so on and so forth. And they added these covariates, age, income, some metrics of how many fast food versus fresh food stores were available in the neighborhood, and so on and so forth, all these covariates, and adjusted for them using various statistical methods, and nevertheless still continued to have this finding. Now, in public health, we face a dilemma, which is that our work is often consequential, and subsequent to this work, a number of headlines of this nature appeared. You can imagine the Fox News commentary that followed, and it, in fact, has elevated to the level in which it has, in fact, become prominently mentioned several times during the current presidential debates. And so our work has consequence, right? Especially when we study programs that are intended to be safety nets. We have to be careful of those consequences and cautious of what they might imply. And in this case, we have a dilemma that is common to public health, whether you're studying the US or any country, and that is common to studying any program, whether it's a safety net program or any other kind of intervention we may do in public health. And that is, we can't control for everything that may be a confounder. Fair enough? We can measure things, as I was discussing with some of the excellent public health students earlier today. We can measure many things in public health. Your age. We can codify your race, although how we codify it is appropriately the subject of much debate. We can declare your income level, your education level. We can create quantitative metrics for all sorts of things, including the density of fast food restaurants and fresh food grocery stores and the prices those. Those are all covariates we can measure. And yet the example I gave earlier today captures what's problematic with it. The example I gave was of Berkeley, California. Berkeley has passed a soda tax, and so it's a very interesting city to study chronic disease and nutrition before and after the soda tax. And you can control for a lot of factors when you try to pick a control group for Berkeley. But you can't control for the Berkeleyness, right? The example I gave to the students was that last time I was in Berkeley, there was literally a man walking his pet llama on the sidewalk. There is something about Berkeley, right, that cannot be measured. These unmeasured confounders can be profoundly influential on health, right? If you live in Berkeley, where there's a nice farmer's market with cheap kale every time you wake up on a Saturday morning, there's something there that may in fact influence your, in this case, nutrition, perhaps profoundly. To give you another example, my cousin, who is a very talented writer, had finished his time studying English at Amherst, and he was a classic undergraduate artist, right? Beret, black turtleneck, thick glasses, always, had the moody beard, right? Tells you how tortured you are. And so he very luckily got into the PhD program in rhetoric at Berkeley, which is a very select program for writers. Came to Berkeley, and I went to go visit him and help him move in. And what had happened? He had purchased efficacy, he was wearing tight red pants and drinking aloe vera juice, right? So culture, one's context, is profoundly influential. And we can't always measure it. What was I going to measure in order to codify what had happened and changed in his health, in his mental health certainly, and from that transition? There was nothing demographic, there was nothing that had fundamentally changed about him. His income was just as abysmal, right? And his environment in terms of common public health variables, density of supermarkets, quality of his apartment, cat allergen exposure, all the measurable things were about the same, right? His cat looked very much the same, just as fat. But these unmeasurables we somehow have to control for because they can profoundly influence the associations between these safety nets and our health outcomes. So in public health, we tend to do a couple of different things. One of the most popular things we tend to do currently is propensity score matching or any other kind of matching, right? Many of you in public health school have this driven into your heads. If we want a fair experiment, we need to compare similar people. So we list out all the things we know about people. If I want to study the impact of SNAP on people, I need to compare myself 35-year-old Indian male physician living in California who's not on SNAP, and find a 35-year-old Indian male physician in California who's on SNAP, and then compare our nutrition. You can imagine then that there's a little dilemma. I don't know frankly, any physicians who are on SNAP given our income. And so matching, when you compare people who are similar, can only allow us to provide conclusions about people for whom a match exists, right? The so-called common support region of the distribution of health. People who are, let's say, too wealthy to ever be considered eligible for these programs are never going to have a comparator. And there are some people who are so profoundly poor that there is no match for them because everyone in their category is on the program. So we can only make inferences about that select common support group. The second problem that we talk about less in public health, I think, is even more nefarious. It's called strongly ignorable treatment assignment, very fancy series of words, which says once we control for everything we have measured, there's absolutely nothing else that can affect both our propensity to go into the program and our health outcomes, other than those measured things. Absolutely nothing else. For studying safety nets, or frankly any other public health intervention, this is a remarkably difficult assumption to hold. One's household history, whether your mother was on food stamps, probably profoundly affects your opinion about food stamps. Whether or not you choose to enroll, depending on how she was treated, how she benefited or not from the program, and so on. Yet these are not captured in our public health data sets. No matter how big the data, the value may not be there because the key variables may not be captured. So in some other fields, sociology, political science, sometimes economics, people use another trick to try to control for these unobserved confounders. What we would like to do in the perfect world is a randomized controlled trial. We'd like to be able to randomize people to the food stamp program or not. It would be the only fair way to say, if we have a big enough sample size, according to the central limit theorem, all those unobserved factors will fade away because an equal number of people with different histories will be in both the intervention group and the placebo group, right? And so all that's left to be different in the randomized trial would be the program itself, the intervention. We can't ethically and sometimes practically or economically randomize people to many of the social safety nets we care about. Very rarely we get the opportunity for a natural experiment, like in Oregon's Medicaid experiment, where people are lotteried into Medicaid, and one could subsequently estimate the effects of Medicaid on their subsequent healthcare utilization and cost. Very rarely are these safety nets subject to such a unique situation, so most of the time we are limited to observational data. So one thing we could do is use a so-called instrumental variable, some factor in the environment that acts as a push, a nudge, to nudge people into the program or not into the program. For example, food stamps administration varies a lot by state. Some states require fingerprinting, others don't. Some states have an automated process where you're already in other kinds of programs, you automatically get enrolled. Other states don't. Some states choose to provide online and telephone-based enrollment. Other states require you to wait in line for 8 hours. You can imagine these variations profoundly influence whether a person decides to ultimately enroll or not. Among the Latino population, for example, you see among eligible people in the states that require fingerprinting a profoundly lower rate of enrollment than in those who don't. One can probably understand why that might be and what the suspicions might be. These factors are probably not related to metabolic syndrome or our other health outcomes, except by way of encouraging people into SNAP or not. Let me give you one more example of an instrumental variable. A long time ago, an epidemiologist named Dahl, some of you may have read his work, was facing R.J. Reynolds, which used to be a tobacco company, and the argument was that tobacco smoking was in fact correlated with what is now called myocardial infarction, heart attacks. But the company came back with a memo and a response saying, hold on a moment, this is reverse causality. People who have heart attacks are depressed, and it's well known that tobacco is a lovely treatment for depression. These people are self-treating. You might laugh as an epidemiologist and say, this is completely ridiculous. But how do you actually demonstrate it when all you have is an observational correlation? an instrumental variable appeared. State sales tax rates, these are the days before official cigarette-specific taxes, state sales tax rates profoundly influenced the number of packs people would purchase, right? Expensive states, places with high sales taxes, one had lower rates of cigarette smoking, and one could track how variations in the overall sales tax rate, varying the level of cigarette purchases, led to variations in heart attack rates that are actually surprisingly profound, or maybe not surprisingly. Sales tax rates won't affect myocardial infarctions in any other way that I can think of. And it's unlikely to be reverse causality that governors seeing high levels of heart attacks decide to increase or decrease the sales tax. Right? So an instrumental variable is something that's sort of a quasi-random thing in the environment that leads one to be able to connect the dots from your healthcare exposure or your safety net exposure to your outcome. But you can imagine difficulty with doing it this way. One is you have to find an instrumental variable. Even with a lot of thinking and a lot of analysis of programs, it can be quite challenging. But the bigger dilemma in the real world is that these are all weak nudges. In a good randomized controlled trial, you enroll people and someone is standing there flipping a coin, saying you go into the intervention group, you go into the placebo group. And with some minimal possibility that people go out in the black market and try to switch for the placebo or for the other pill, which is hopefully small in most well-conducted RCTs, that person is a strong randomizer. You're really trying to equalize out who ends up in the intervention or placebo to make strong causal inferences. But these factors, these are just little nudges. They're very weak. Maybe you won't fill out the enrollment because you're getting fingerprinted, but most people still do. Right? So a newer study design approach that we've been working on is a way to combine these two principles in order to strengthen and overcome some of the weaknesses of each one. It's known as near-far matching, and it mimics a randomized trial in which you have matched pairs. Here's the idea. You match people to be near or very similar to each other on observed characteristics. Find people of similar age, sex, race, income, ethnicity, and so on and so forth. But simultaneously also match them to be far on measures of an instrumental variable. Otherwise similar people, one of whom is just across the border in a state where they do fingerprinting, one of whom is not. What does this do? Statistically, it massively increases the power of your instrumental variable. Similar people facing the same nudge tend to differ for reasons only related to the nudge. And so it's a statistical trick to really increase power dramatically. In this case, using the instrument, so you randomize, you get the power of randomization, correct for your unobserved covariance, but really fix the weak instrument problem by otherwise having matched people. Scott Lorch had a nice demonstration in pediatrics of this, where he was studying people who lived nearby to specialized care that needed it when they were having complicated pregnancies to those who didn't. It was difficult to use anything other than distance as an instrumental variable to determine whether or not the mother was ambulanced into this special center. And he was able to strengthen that instrument in order to compare fairly people who had same levels of complexity of pregnancy and whether or not the complicated specialized care hospitals were in fact making a difference. To their chagrin, he did not find any significant results. But here's the interesting thing about when we start studying SNAP and the relationship to obesity or metabolic syndrome or any number of adverse health outcomes. Once we do the analysis this way and add the randomization factor of these instrumental variables, our effect mostly goes away. I don't know exactly what it is. There were unobserved variables. Maybe it was personal history, some aspects of the environment or the food environment or the local cultures around places where people were heavily SNAP users, but those factors were explaining the correlation between SNAP and these adverse outcomes much more, with the exception of very long-term SNAP users, particularly among long-term SNAP-using women. And what was interesting is this relationship also washes away when you start strengthening your instrument even more by getting closer matches from larger data sets. Effectively, we make a positive result null. So a little dilemma I have here is, suppose we buy the idea that this supplemental nutrition assistance program might not be worsening outcomes, that there are all these other factors going on leading to this false correlation. That's still very dissatisfying, because if you're going to have 1 in 7 people in the United States enrolled in a program that says nutrition assistance, and if chronic diseases related to nutrition are in fact a major cause of a burden of disease, then you would hope that the effect isn't simply at best null, but that there's a beneficial effect going from the program to your health outcomes, right? Especially if you're spending $80 billion on it. And so there have, of course, been many theories in the public health literature about what might be leading this relationship to at best be null, and in some circumstances, when you don't do statistical trickery, it's an adverse relationship between SNAP and nutritional outcomes, because that is ultimately very disheartening and disturbing. And there's many common theories. The first one, of course, I don't think this audience will be particularly sympathetic to, but it's one of the most commonly stated in more of the public literature. It's inadequate education and not enough, quote, health promotion among those who are receiving SNAP. The second and third theories were those that I was more wedded to, and as I'll show you in a moment, have not panned out as well as I had hoped, and led me down a different path of thinking, which was the lack of availability of healthy foods, or conversely, the excessive availability of unhealthy foods, and the lack of affordability of healthy foods, or conversely, the widespread cheapness of unhealthy foods. These are all mechanisms we can all understand. It doesn't require any specialization to see these as potential mechanisms. Let me go ahead and dismiss that first theory about health promotion. It's remarkable how much money has been spent on nutritional education in the United States, surprisingly perhaps, and particularly in association with SNAP, much of it mandatory for people who are signing up for food stamps. Much of the education has used the latest and greatest theories in psychology and behavioral economics, health communication, social media studies, had expensive contractors with experience in design, all sorts of really advanced efforts, always with null results. Sometimes I read the health promotion literature and I feel like I'm reading a religious text that says the Messiah is coming tomorrow, and somehow we just haven't kept missing him, right? Health behavior change will be around the corner from just the right combination of education programs. And yet, consistently in large, well-conducted, randomized trials, not just in the United States, but around the world, the results, other than the negative ones, are largely neutral. Very disheartening. It would be lovely if this were true, but I have a hard time believing that someone will finally find the key clinching way in which people will profoundly, suddenly just do the right thing. And this is when I admit that as somebody who studies chronic disease, I ate a big piece of chocolate cake last night. Okay? It has to do with all sorts of other factors and desire and being human. On the other hand, I was disappointed to see the continuing wave of results for the theories that I had thought would be really good explanations of the variance. Increasing availability, excellent, well-conducted, community-based participatory research with well-constructed, long-term thought in order to produce fresh fruit availability in a number of pilot programs around the United States have sadly not resulted in the types of improvements that I had thought they would. And usually, again, there's a little bit of religiosity here. Someone always comes up to me after lecture and says, in my neighborhood there is a new one and it is being used, and that's great. But unfortunately, in some of the large, well-conducted RCTs, all 7 of them that I'm aware of, the results have been largely neutral. In many of the follow-ups, unfortunately, a lot of the stores have closed. This is not what I was hoping for, right? So this became disturbing and puzzling now. And perhaps most of all, increasing both purchasing power and the affordability of the healthy foods, or conversely, decreasing the availability and cheapness of the unhealthy foods, has also been surprisingly, though often effective with a p-value of 0.049 in many studies, not really of the effect size one would hope for. Perhaps the largest was this Healthy Incentive Pilot Program, which had a massive 30% subsidy for fresh fruits and vegetables. This is larger than any subsidy I've ever seen for a direct-to-consumer subsidization of healthy foods. And yet, the increase in fruit and vegetable consumption was minute. Amounted to like about 1/4 of a carrot per person. Not what I would clinically think of as meaningful, right? It's had that P of 0.049 where you kind of wonder how much was massaged to get to the significance level. Okay? Really disappointing because I was hoping for good results. So we have a choice in public health, which is when we get results that demonstrate our hypothesis may have been wrong, we have two choices. We can double down on our original theory, find minute ways in which the numerous RCTs conducted at different sites by good people in careful ways somehow just kept missing the mark. Or we can go back to the drawing board, go back to our conceptual model and think about why we might have been wrong. So suppose we went to the broad spectrum of evidence. Availability and price interventions that I had hoped would work. Large-scale systematic reviews, meta-analyses, network meta-analyses, finding the available evidence was just truly insufficient at best. And this is written by the people who had favored the theory, so it really takes a lot to admit this. Then maybe we should reconceptualize our model. How is it that people are fundamentally purchasing their food? And critically, how is our safety net interacting with this? Let's think for a moment about the nature of being on food stamps, and perhaps go, for example, to the ethnography literature, which describes in great detail what it is like to be on the SNAP program. So, on the first day of the month, typically in most states, although this is somewhat staggered based on your last name in some states, you might get it on a different day of the month, but usually one day near the beginning of the month, you receive electronically a deposit on a debit card. There's no announcement or notice, but among SNAP users, people very much know on which day and sometimes even which time is typically gets registered. They are typically hungry, very hungry. Their kids are usually very hungry because the prior week most people had run out of food. And they do what any sensible consumer would do. You just got money for food and you're hungry, so you eat. And as sensible consumers, most people on SNAP go to big box stores or bulk food stores and purchase economically. They purchase things in bulk because it's cheaper per unit. They store a lot of it. A lot of it is refrigerated if they have refrigerator access. Otherwise, a lot of it is packaged if they don't. Right? And it's stuff that they can purchase as much as they can with that once a month deposit. They then go through a cycle in which during the hungry first 2 weeks, a lot of it is just consumed. Perhaps more than was intended, but they're hungry. And then near the 4th week in particular, both the funds are out and the supply is typically out. And then the cycle repeats itself. Right? The cyclical consumption is really profound. This is expenditure of food. And one notices that, going to other places like restaurants and so forth is, of course, a minority of the spending and stays relatively flat. But the food that is purchased and brought home to be consumed at home goes through this enormous cycle every month. As a clinician, to me, this has profound implications for patients' health. First of all, if one consumes a lot of calorie-dense foods, particularly in the beginning parts of the month, obesity is not such that having a calorie deficit later burns all of that obesity off. Unfortunately, it doesn't work that way. The calorie-dense foods have consequences overall. And for metabolic syndrome and type 2 diabetes in particular, the impact on the pancreas and insulin resistance and so on is real and can't be neutralized simply by being hungry later. Interestingly, in California is where this data is from. Towards the beginning of the month, people who have type 2 diabetes who are on food stamps, the SNAP program, tend to have hyperglycemia be the cause of their emergency department visits and inpatient hospitalizations during the beginning portion of the month. At the end of the month, they have an increasing risk of visiting the emergency room and being hospitalized for hypoglycemia, too little blood sugar. And the cycle continues. Note that the cost of these hospitalizations is actually profoundly more than the cost of increasing incrementally the amount of food stamp required to avoid the cycle, according to other studies. And this cycle doesn't occur with other conditions for which there's just a random probability throughout the month of getting it. I didn't purposely pick appendicitis, but it's quite flat over the course of the month. Interestingly also, and perhaps explaining the disappointing results from the new stores coming into the neighborhood experiments, most people go quite far to go to their primary store, even among the poor, even among SNAP users. Even when they have a low-cost, fresh fruit, subsidized grocery store in the neighborhood, most people will go to the place that is most economically beneficial for them in terms of the volume of food that can be purchased for the dollar, which are the big box stores, Walmart, Costco, and so forth, even if they have to drive quite far. Perhaps explaining why those new neighborhood stores are not quite having the oomph that they could have. What can we do in this circumstance? One of the interesting literatures that has gained much attention is the idea that when under conditions of profound resource deprivation, no matter who you are, no matter what educational background you've been given or additional interventions you have, the ability to make decisions over the long term is profoundly curtailed in favor of the shorter term decisions that you need for survival. So for example, when highly educated graduate students who are conveniently enrolled into a psychological experiment were given a task in which they were in the game, a video game, given very low amounts of money and told to score more money in the game through gambling, they profoundly borrowed even when it was an extremely bad level of interest rate with conditions that would inevitably lead them to lose the game. But when they had some in reserve, they only borrowed when it was really sensible. And similar experiments done by the psychology and behavioral economics crowd have observed similarly that under conditions of deprivation, it's easier to make shorter-term decisions than very long-term ones for a number of issues that lead to longer-term chronic disease. These types of studies lead one to theorize how one might alter safety nets that cycle, like this food stamp program. On one hand, you could have the same amount of monthly benefits, but divided up instead of this once-a-month deposit into weekly or otherwise frequent deposits for a continuous or nearly continuous infusion of funds. The theory being that that would enable people to also think about longer-term things rather than always purchasing out of desperation, and to be induced into purchases that aren't necessarily the packaged food products, but things that can be consumed on the shorter term, i.e. fresh fruits and vegetables. But they may be a poor theory. On the other hand, doing these frequent benefits may just make life very difficult. Now you have to balance going to this big box store multiple times of the month with smaller amounts of cash, rather than once a month and planning out your month. A natural experiment occurred in Peru to test this theory. Peru initially had their benefit program, equivalent to SNAP, administered twice a month. Apparently, System Center 2012 endpoint protection is having an error. Sorry. All's well. But Peru switched from having a twice-a-month deposit to putting the same total monthly amount just once a month, as is done in the US context. And notice these profound shifts in how people use the same amount of monthly money, as compared to people who were in a control group because they, for a variety of administrative reasons, their provinces hadn't been reached yet. The group that experienced the shift had a lot more alcohol, tobacco, sweets, soft drinks, and prepared food purchases, even though their total amount of consumption didn't change. In other words, this once-a-month cycle was somewhat induced by the safety net itself. The converse of experiment we've been doing in San Francisco. The city has decided that it will, in addition to whatever goes on in the federal place, subsidize low-income families with fresh fruits and vegetable vouchers. They're kind of like the women, infants, and children vouchers. They appear like a check that you can hand to the cashier. And so a little experiment was done among those who consented to either get it in a once monthly lump sum or in weekly checks, even though the total monthly amount was the same. And the folks who did it in the weekly installments were those who had the significant and rather clinically meaningful rise in fruit and vegetable consumption. In fact, they met the federal Healthy People 2020 guidelines for the first U.S. population to actually achieve that. And interestingly, had substituted out a number of products we don't think of as very healthy: refined grains, added sugars, and some added trans fats in particular. And these weekly cycles among the groups that had diabetes were also eliminated in terms of their sugar level in the blood and their overall diabetes control. A similar experiment in Philadelphia with the WIC voucher showed identical results. Now, I'm not so naive as to suggest that just adjusting benefit cycling is going to be a solution to the challenges of nutrition among this group. In fact, all these behavioral economic theories are very much in the vogue at the moment, but don't address the heterogeneous treatment effects within the crowd. That is, why some people didn't benefit. There was a profound number of people who didn't benefit, even though the average treatment effect was significant, because of injury or illness, often housing instability, and what I call time poverty. That is, the only time that they had available to shop when you mapped out what they had to do during the day between jobs and childcare and a number of other things was often 11:30 p.m. at night. I don't know about you, but at that time I'm watching Netflix, not grocery shopping. So some of these subtle adjustments perhaps will allow us to improve safety net programs, but there are other issues here that are still fundamental to the nature of poverty and safety nets that are unresolved. One of the largest debates that has taken place in terms of addressing these fundamental other dilemmas is, should we then provide benefits that are more generalizable? Rather than being conditional, here you get this one for food, you get this other voucher for housing, you get this other voucher for insurance, and so on and so forth, this piecemeal system of highly complicated benefits. Should one do an unconditional income transfer? It's an interesting question. It's gone on for many years, and I think I can summarize the literature briefly by saying a huge number of papers show absolutely no consensus. The outcomes are widely varying. It depends on how one measures them. A large portion of the literature is in the education field. Most of the studies are highly confounded. But what's really interesting is the public discussion of the literature is extremely focused on the one issue of worthiness. Not on the issue of effectiveness, but on worthiness. Are people worthy enough to receive an unconditional income transfer? One of the dilemmas with framing it this way is that we tend to not ask the question of what have our prior actions actually done to the state of risk and vulnerability in public health. For example, one of the largest welfare reforms in our country's history occurred in the mid-1990s, the transition from assistance for families with dependent children, what used to be called welfare, to temporary assistance for needy families, TANF. Right? Profoundly and suddenly, the amount of people on welfare dropped from around 14 million to about 5 million. Tremendous population shift. And remarkably, there's about 4 public health papers on it. Remarkable. Lots of economics papers again, studying things like employer benefit packages, economic growth outcomes. Many papers obsessed with whether or not people were married more afterwards. But from a public health perspective, this is rather profound. A large number of people, particularly single mothers with dependent children, now had a work requirement in order to receive benefits, and even those benefits were fairly temporary, about half a year. So there's a problem again, which is how do we study this fairly? If you want to study in just a pre-post analysis, well, there was all sorts of things going on at the time that could confound your experiment, right? Before and after 96, I think the dot-com bubble burst. There was all sorts of different employment effects going on, all sorts of cultural things. Who knows what's causing the effects, right? So you need a control group. Who are you going to get as a control group for single mothers with dependent children? There's no ideal control group. Fair enough? And what's been done a lot in the public health literature is either a simple pre-post analysis, for which you can't even control for a time trend, or classically a difference in difference analysis, right? If you read all the papers on the Affordable Care Act and how much it's affected healthcare utilization, cost, equity, and so on, they all use difference in difference analysis. What it means is you pick a group that's affected. So in the Affordable Care Act, it's people who went from being uninsured to insured under the Affordable Care Act, and you try to pick the best control group you can find. Okay, often very hard. So for the Affordable Care Act, you have some natural control groups. You pick people who got covered under Medicaid in the states that expanded Medicaid and compare them to the people who didn't get covered but were otherwise similar in the states that didn't expand Medicaid. And you control for the other measured factors, and you look at the changes in health utilization before and after the policy. Fair enough? That's on the left there. That's the difference in difference analysis. You can see, of course, that there's problems comparing people in states with Medicaid expansion versus without. Those are usually comparing blue to red states. There's probably a lot of other stuff going on there. One of the newer methods we've been testing and deploying is a bit different. It says in most of the interesting cases where you have a natural experiment with a safety net, you don't have a natural control group. Usually a very imperfect one at best. But you usually have many highly imperfect control groups. So can you, in fact, combine and sample from those imperfect control groups in order to create a so-called synthetic control, an artificial control group made up of components of the imperfect control groups that are somehow reweighted to match better with the intervention group? And in this article by Abadi, he goes into a formal proof in which you can actually create a weight for unobserved confounders over time if you have longitudinal data. So you can create a weight and account for those things that are unmeasurable over time and also control for them, making essentially an ideal control group for times where in public health we have an interesting place that's doing something, Berkeley with the soda tax, New York City Department of Public Health Policies, et cetera, where you don't have a great control for the Berkeleys and the New York Cities and so forth. Doing this, we combine many groups that are demographically similar to single mothers with dependent children, but for various reasons had missed the cut points for being on welfare and created a synthetic control to compare them against. We did the classic difference in differences model and the synthetic control model, which showed some stronger results. But in any case, the outcomes were generally worse health after welfare. But after welfare reform, excuse me. In other words, with the work requirements and the shorter duration of welfare, a number of health behaviors and outcomes were worse. But the first thing you notice about this slide is not the health outcomes being negative. The first thing I noticed when this popped out of my computer was the massive error bars. Right? Not precisely estimated. If I got this out of an RCT, I'd be very concerned about the nature of how the trial was conducted. And what this suggested to me is perhaps I was asking the wrong question again. That it was not just a question of the overall effect size being worse in this case where transfers became conditional from unconditional, but rather whether I was lumping together a group of people for whom commonalities in effect should not be expected. That is, we are studying these safety nets from the perspective that all of these people should somehow be affected in similar ways. Right? We give an intervention, we expect them to be similarly affected, and yet all that they really have in common, in this case, is the same income, or even just being similar and being less than a certain income threshold, which is not a very great similarity. So does that raise the question of how we might better adjust our safety nets to be a little less crude? As another example, let's take the largest poverty relief program left in the United States, the Earned Income Tax Credit. EITC is profoundly associated with a number of economic beneficial outcomes. It's a tax credit that's given annually to the poor, typically in February, after the IRS has processed their returns. But when we look at health behaviors, my colleague David Rakoff did a natural experiment when he compared health behaviors during the months off the EITC to the months where people received the EITC. Some health outcomes improved, some health outcomes became worse depending on who you were. Many people did spend their EITC on alcohol and tobacco. Don't tell the Republicans, but it happened, right? And so you have here a blunt instrument for income transfer that is not associated with a health improvement, even though we believe that income improvements are associated with health improvements. Fair enough? So this leads me to the question of why we should expect more than blunt outcomes from very blunt safety nets. One thing that we're trying to do instead is, rather than debate about conditional versus unconditional, or rather than debate about what the mechanism of transfer should be it be a tax credit or should it be a check? Well, guess what? Effectively, it doesn't matter, right? It's actually just the same income transfer. What about whether we created safety nets that were supportive based on the varying circumstances that are actually experienced by the people who are eligible? For example, among some of my patients, there are some people who are going through one bad spell. They'll do fine if they just have SNAP for a few months in order to get through it, and that's it. They'll be fine afterwards. There are other patients for whom I basically want to find some way to purchase them a new life service. They need their apartment cleaned up. The hoarding thing needs to stop. They need to be able to get both income and job security and training, and they need the food stamps, and they need employment training. And there's many, many people way in between, right? For different things. Some people need the SNAP, other people need the housing. For some people, the two go together, and for some, they don't. What we've been trying to do is, with the centrality of a single case manager, do trials that are so-called SMART trials. This means sequentially, multiply adaptive randomized trial, which is a fancy way of saying, instead of just randomizing people to do intervention versus placebo to tell whether the program works, we first say, let's start with the first phase. You get your welfare benefits versus whatever you would have gotten otherwise. And then among the people who that doesn't really work for, we say, what did you need that was different? And re-randomize them. The addition of the housing voucher or not. Among those for whom that doesn't work, we re-randomize them to the assistance of a case manager versus not. Different people have different randomization pathways. And as Susan Murphy and others who have developed this trial design have found, there are ways in which, even with moderate sample size, you can get profound statistical power to make inferences on who are the types of people who need different combinations of benefits and of what form. There's all this talk about personalized medicine, especially at my institution. Profound amounts of money spent on genotyping what will probably explain roughly 0% of the variation in disease at a public health level, right? I get in a lot of trouble when I say this at Stanford. So if you're spending all that funding on precision medicine, I think we can do a little bit for precision public health. And it's not even that precise. I don't mean doing genetic code. I mean maybe zip code, and then maybe neighborhood and household and individual level to some extent. But really being a little less blunt, if we really expect these social and economic determinants of health to truly be determinants of health, then we may need to be a lot less blunt about how we address them for different people. The trials that have been conducted have been generally encouraging. and 5 cities in which various substance abuse and mental health services were adapted in this style. Various city-level costs, which is often one of the primary outcome measures for the cities funding these studies, have reduced. Housing rates have improved, and various mental health and physical health measures have improved. Toronto has one of the most effective of these, but interestingly, it is depended greatly on the level of integration. Among those without psychiatric service or medical service integration, the only metrics that have improved are those other than the psychiatric or medical services. Similarly, in Boston, Salt Lake City, and here in your great city, a lot of cost savings has occurred from trying some of these designs. Not all of them have been SMART trials. The Seattle one was a large RCT. But of integrating the housing support system with some of the employment system, with some of the voucher system, with some of the SNAP system. So rather than going to 10 million different offices, a case manager helps one determine what is needed to get you back on your feet, both mentally, physically, and income-wise. The costs for the city have been rather profound, and have been one of the ways in which this has been most compelling for the people often funding this, which is a reality of doing this. As these trials go on, I want to wrap up a little bit by discussing what I think are some next steps and open questions for those of us in the public health community. I think for many of us, when one looks, let's say, at the National Institutes of Health applications for large grants, what one sees is sort of the kitchen sink approach. For nutrition programs, for example, we'll have this huge weight loss program with people text messaged and Facebook reminded and Twittered and called every day and having a case manager, and they're going to have a wireless scale, and they're going to have a Fitbit. All of this, of course, during an 18-month window, because that corresponds perfectly to the amount of time you need for recruitment, randomization, post-trial analysis, and publication within the 5-year grant timeframe, right? And because it doesn't work, next year you submit the application again, saying in our preliminary research when we did 60 subgroup analyses, one of them had a p-value of less than 0.05, which indicates that we might be able to improve it slightly. You add another component, right? One more component. Instead of Fitbit, it's going to be Fitbit Plus, and we redo it all over again, right? And so I think we can rethink this a little bit. I think this iterativeness, conditioning on the nature of the people that we're trying to affect, and how we can improve delivery, particularly across classes where we believe the common underlying social and economic factors are similar, are ways where we can try to address some of these persistent, almost nefarious things that have not budged for us in the United States public health sphere, nutrition and substance abuse often being amongst those that are most challenging. I think for epidemiology, the environment for doing randomized trials on safety nets is, I think, finally arrived. We've only been limited to observational data for a lot of these. But if we're going to spend $80 billion on a particular program, I think it's worth spending a fraction of that in order to do a well-conducted RCT. Otherwise, the debate will continue as to whether there was some minute amount of unobserved confounder, no matter how fancy the statistics, that led to some nefarious conclusions about the intervention's effect. I really think that some of the analysis with regard to iterative design is an opportunity for those of us who study safety nets to try to understand heterogeneity in treatment effects and who is being affected by which program in different ways. And then to the policy question. I joked about the Donald at the beginning of the presentation, but it is the political environment is a cloud that hangs over this conversation, whether we like to admit it or not. And I think in this context, many of the initiatives that I see that provide optimism are those that often take place at a smaller level, the city, the county, and the state level, and particularly at the city levels in many cases, are where some of the people who are truly interested in effectiveness are really capable of managing and interpreting data, are very interested in actually advancing this kind of discussion. The federal politics, I'll admit, very hot and heavy. That is where the capital is and where the funding is, and that is a dilemma I haven't figured out. If some of you have figured it out, I'm all ears. But it's really a point at which actual experimentation or discussion of the data, and I think at this level of discussion, has not, in my experience, however limited, been possible yet. But perhaps in the future. I'll end there. Thank my collaborators who worked on many of the research projects that you saw here, and take any questions if we have time. Thank you.
I think we have about 15 minutes for Q&A. So,
Sure.
So you presented a lot of evidence on what doesn't work, and you presented it very well, and you've given some hope for downstream effects. Can you go upstream and address the issue of why among rich countries we're dead first? Why is our health lagging so far behind? It's probably not within the details here, it's something much bigger picture.
Yeah, thank you for that question. I think the Institute of Medicine report that came out a few years ago was actually rather informative, and then went systematically through the various theories. Is it attributable to our healthcare system? Probably not. If you're talking particularly about life expectancy disparities amongst countries. Is it attributable to obesity? Probably not. It started well before obesity as a singular issue became a major factor in the United States. Is it attributable to tobacco smoking? There was sort of hedging on that point. Maybe some of the decrease in life expectancy is a cohort effect in which the United States has profoundly lagged in the past, and then European countries somehow followed. But it doesn't quite jive with the evidence, and certainly doesn't explain the majority of the variation, especially because we all know the French smoke like chimneys, so it doesn't really work. I think underlying it all was the chapter that went missing from the IOM report, which was the one that related to economic inequality and the fact that average life expectancy disguises what the distribution looks like. So in the European countries being analyzed, not only is life expectancy higher, but it's also a narrower distribution. And in the United States, life expectancy isn't always less, right? It overlapped with the European countries on the right tail and went beyond, But then there was the left tail, where we go so much further. And hence the mean and the median are therefore lower than in the European countries. And I think therein lies some of the explanation. We have chosen to accept a level of inequality that is not acceptable, and that it is related very fundamentally to income as the variable that of the observed measured variables in those regression equations explain more of the variance than any of the other variables, more than even the proximate ones, which I find interesting.
So what do we do?
Well, I think many of this is about how we choose to redistribute income, right? So if you look at capital flight in this country, it's not all that different from some countries that experience mass capital flight. So everyone is criticizing Greece for allowing capital flight where nobody pays their taxes and so on. But as a proportion of generated income, they've actually taxed just below what we do effectively, because we permit so much in the way of tax havens. It's interesting to me that when the Panama Papers came out, there's really very few, if any, Americans on the list, right? And so what is the reason for the fact that we don't have the richest Americans going to a semi-legal, maybe illegal law firm to produce strange tax havens? It's because they don't need to, right? It's legal, right? In other countries, it's called corruption. Here, it's just politics. So I think that's something to be said in the fact that the legal loopholes are profound in terms of the sheltering of capital, and from an extremely small proportion of the population. That, of course, is a very difficult task, and I don't have a solution for how to pass it politically. Yeah.
Thank you for a great talk. The other Donald in our life in recent years has been Donald Rumsfeld, who talked about the known unknowns, and I think that's sort of starting to give some shape to that bizarre phrase, some of what you were talking about. You do point out that a lot of the resources for income redistribution are at the federal level, but maybe there are some solutions at more local and state levels. On the other hand, funding for public health research of this nature is not really available at the local or state level. It's not available at the university level. And at the federal level, we're really only interested in studying germs of one sort or another. And so where do we get some sort of better vision for spending our public health research dollars?
Sure. Now, I'll disclose right up front that I've received federal funding for some of this work. But usually I don't phrase it in, to be quite frank, in my NIH grant application as fundamental to the nature of inequality and income redistribution, right? We talk about the ways in which we can adjust public health interventions in order to produce better efficacy for proximal health behaviors and outcomes. And I think therein lies a lot of interesting language, because it's dangerous from the perspective of federal funders to say that they're funding something that's fundamentally about societal choice, right? It's very easy to fund something on health behaviors because that's an individual problem. And I think that would then imply that, you know, through whatever psychological or behavioral economic trickery, we can just improve the masses from their bad behavior to good behavior. That's sort of what underlies the conceptual model there. And I think it would be tremendously hard to envision in the current environment how federal funding agencies would be able to move out of that space. But I do think that there are opportunities to demonstrate through the data that we have available that one can get greater efficacy by addressing societal dilemmas, whether it be the adjustment of safety nets or other approaches, than we have seen from the health behavior literature, right? Because the health behavior literature gives us an excellent placebo. Actually, less effective than placebo in many cases, right? So one has to ultimately say that if you're really interested in evidence-based public health or evidence-based medicine, then you would have to, at some point, address the fact that the approach that's been the dominant approach so far has not resulted in a major improvement in the variance and health outcomes. And I think there are some people who are genuinely able to come to terms with that, even from within large federal funding bureaucracies. So I think there's some hope there. But it is under the political environment in which the NIH is called to Congress in order to justify itself. So I think they're in a difficult position.
So thank you so much for your presentation, and I think no one can deny the importance of these safety nets. As a young student, I think it's partially my job to imagine a better society in which we don't see 1 in every 7 Americans on food stamps.
Mm-hmm.
So what suggestions do you have for us students in public health to study? Because, you know, these safety nets are treating a problem that doesn't have to exist. And we are bounded by what you said with the research dollars coming from federal sources. And if we truly want to change the situation, do we need to resort to activism, or am I in the wrong field?
So let me answer the question in 2 ways. The first answer I would say is that the question of whether you're going about your work and your research in the right way is not a question that goes away once you're done being a student, at least not for me. It is a question you learn to live with. And you know, it is a question that you can build confidence around as you proceed with your career. But I don't think it's a question that will go away after degree is conferred, unfortunately. But it's also good in a way because it allows you to rethink. You know, I was very disappointed when I saw the results of the grocery store intervention trials and the subsidy trial. Because those were, you know, fundamental conceptual models for determining the future of how we might fundamentally improve nutrition in the United States, or that's how they were envisioned. And there's still most of my colleagues who think that there's just something, you know, a little off about the study design, It'll just improve the 8th trial that we do. But I think what it allows you to do is, being in a field like public health, which has the sort of curse as well as the privilege of actually being consequential, right? I mean, some of my colleagues in theoretical physics have a lot of fun, but then at the end of the day, their work may be consequential. But as one of my friends says, probably not, ever. So we're in a field where we have that privilege, but also that curse. I think the opportunity for you then is to look at people who are preceding you and to criticize them and see what the holes are in their work, and to go where that leads you, which may not be fun at first, but I think provides you with the opportunity to actually say, you're trying to address, from a statistical point, the portion of the variance that is not explained by your predecessors, right? And I think that's a good place to go. I know that may be an unsettling place, but I think that's a good place to go.
So I guess as a related question to the earlier questions, it's really stunning. You're doing the work on safety nets now. I know as much of what you're citing of your own work is just very recent. That there's only 4 studies of one of the biggest eviscerations in recent history of this country of safety nets.
Mm-hmm.
There's only 4 good public health studies. I mean, that just seems to speak volumes about the vision of our current public health discipline. And I'm wondering, if you have suggestions for students and faculty, how do we change that? That means that our optic, our vision is somehow off in some fundamental way, that something this important is not getting its due day in the scientific community. And I think it reminds me of your book on austerity as well, is that you're one of the few really good sources out there about how this huge economic transformation in Europe and other parts of the world is affecting public health. I don't know if you have an answer to this question. How do we change the optic here? How do we shift the vision in some way?
I think in part, thank you for your question, I think in part it's considered socially inappropriate for us to go as far down as to study the actual implementation of a policy. In many ways, and part of this I think has to do with the deep tie to clinical medicine sometimes can lead us to want to only do the abstract or the basic trial and not the messy, how is it being implemented in the real world trial. Even within the fields of public health that work with, say, safety nets, what do we cite the most? What have we cited the most recently? Let's say the Medicaid organ experiment, which I referred to. The Medicaid organ experiment is very interesting. It's a natural experiment where people are lotteried into Medicaid in order to see subsequent outcomes. And the outcomes were pretty strange, right? They reported increased ED visits, maybe some decreased depression, not really much effect on other health outcomes. And then if we look at that RCT, what do we find about the population? They're Oregonians. Even among the previously uninsured, they had much higher health access than the rest of the country before they received insurance from safety net hospitals. And they had about 1/5 the chronic disease rate as the rest of the country. So it's interesting that it's randomized. That's about it. It's interesting that it's randomized. Similarly with the Moving to Opportunity study, we cite the Moving to Opportunity study a lot as a housing voucher program that was very carefully studied in 5 cities, where people were randomized into getting a housing voucher to a low poverty neighborhood, a regular housing voucher to any neighborhood, and control. And among the being randomized to a low poverty neighborhood, people had lower morbid obesity and type 2 diabetes, as well as some improved mental health scales. Great. But if you look at the study, it's this idealized experiment in which people were basically forced to move to a different neighborhood, right? And actually, even among the intervention group that did move, they only moved on the spectrum of a couple miles for the most part, if you look at it geographically. Why is that the case? Well, it's sort of considered somehow not right to actually look at actual HUD programs and how well or poorly they're actually relating to public health outcomes. We did this just recently and actually got the linkage from HUD. It wasn't an administrative problem. We asked them and they're like, oh, no public health researchers have asked for this. Here's the data, just sign a non-disclosure agreement and make sure you don't identify people. It was one of the easiest data transfers we've ever had. We were able to link it to 10 years of the National Health and Nutrition Exam Survey, NHANES, and say, let's look at people's blood pressure, cardiovascular mortality over the 10 years from 1999 to the point at which the National Death Index was measured in 2011. And surely enough, actual implementation of housing choice vouchers related to rather significant declines in cardiovascular mortality, mediated by all the pathways you'd think it would be. Blood pressure and so forth, stress-related parameters, and so on. And regular public housing, nothing. Slight increase, although not significant. Because, I don't know, all their stress levels are way off the roof. They're all in these concentrated poverty locations and so on. But somehow it's sort of like unseemly not to do the ideal experiment and to actually study the implementation as it's being done. And yet, you know, in the case of the housing voucher and HUD programs, that's 5 million folks. So we're not talking about small, little demonstration things. These are really large programs. I think the opportunity is there to actually study a lot of it, but it does require a lot of this administrative linkage, a lot of efforts in order to try to get good controls. And also to just sort of get over wanting to just answer the psychological theory and literally just say, is this effective in a very brute, observational way?
Again, a huge thank you to you.